that can help them manage their health plans more effectively. This treasure trove is called Big Data, and it's full of medical claims, workers' comp claims, and other types of information that employers can use to make predictions about health risks, outcomes, and employee behaviors. It can help an employer determine if their employees are likely to develop a particular disease or chronic condition, and that enables them to tailor their health and wellness programs to meet those needs. Using a scientific approach to manage health plans and wellness programs is a pretty new concept for employers, but many are discovering its value. And thanks to consumer and regulatory trends, there is a rapidly growing amount of healthcare data to mine. But the challenge for employers is learning how to collect and use that information to improve health outcomes and manage costs. To help us better understand that process is George Pantos, a leading expert in technology, population health management, and analytics. George is the executive director of the Health Performance Management Institute, a Washington-based research and education organization that studies the use of business technology and management principles in improving health benefits delivery. So with that, I'd like to introduce George.
Thank you very much, and a big hello from the nation's capital. While people up on Capitol Hill are busily trying to fix that big ATM machine, it seems to be broken right now, attention seems to be shifting also to the cherry blossoms that are blooming on the tidal basin. So it's a glorious day in the nation's capital, and I'm delighted to be here to share some information on big data and population healthcare management. I would like to maybe start before getting into the topic with a little background about the Institute, which was founded about 3 years ago by a group of business leaders. The purpose was to foster innovation in healthcare management, and also to advocate new concepts of workforce population health management. Basically, our institute is focused on research, education, and advocacy, and our mission, I think, holds much promise because the trend is clearly now toward new ways of delivering healthcare, and as well as exploration of new business methods of managing health plans. Clearly, we're not out there yet, but we're getting close. Change is in the air, and I believe it's safe to say that progress is being made. By way of background, from my own background, primarily in the private sector, although I have had a brief stint in the government, I have a legal background with nearly 30 years working with a major law firm on behalf of employers on employee benefit legal issues. That's by way of background. I've taken a new path now in semi-retirement as a researcher and as an advocate, focusing primarily on the health cost problem and on how technology and how business management principles can be applied to improve health plans' performance, with the ultimate goal of improving the health of workforce population. And today I would like to tell you about this effort and what is happening around the country by many employers who have embraced this concept of using data to improve the performance of their health plans. At the outset, I think we could all agree, I believe, that we're in a period of unprecedented rapid shifts in the nation's healthcare landscape. This shift is taking place both in terms of national reforms, health reforms from the legislature, and as well as advances in technology. And both of these shifts are impacting on the U.S. healthcare system. Unfortunately, however, we are still experiencing skyrocketing costs in spite of these shifts. I want to start by focusing on some key trends impacting the healthcare landscape and outline some choices that are available facing health plan managers in responding to these new realities of the 21st century. Especially today, I would like to talk about some choices of strategies that are available, which remains a major source of healthcare coverage. While the 2013 landscape is far different than it was a decade ago. There's one important constant in all of this change, and that is the U.S. employment-based healthcare system, which remains a major source of coverage for most Americans working, and is with us in spite of some hits it's taken recently. In other words, while facing some stiff headwinds, the fact remains that over 61% of working Americans are still covered by employer-sponsored group health plans. That's an important fact. And the ability for those who are still offering benefits to think in strategic terms, and this is a slight shift perhaps in the way that traditional approach to healthcare benefit management has taken place, but to think strategically in terms of an approach that aims to improve the health of the entire workforce population. That was not simply the focus going back several years ago. But it is the starting point in our new thinking. And this strategy revolves around the central idea, it's a key component, of harnessing data as part of a comprehensive, and I emphasize the word comprehensive, population healthcare strategy. A new report just yesterday, I believe I saw from consulting firm McKinsey, says properly leveraging big data in healthcare could mean up to $450 billion in savings. That's 12 to 17% of the 2.6 trillion baseline in U.S. health-related spending. These are ambitious goals, I'll be the first to admit. But this strategy puts a healthier workforce at the center of the corporate culture. The McKinsey report says an important step in this strategy is encouraging individuals to take more active steps to improve their own health. Now that's the key tenet I'll be talking about. An equally important goal is developing an integrated approach to care in which all caregivers have access to the same information. They're all on the same page. So big companies and startups are leading the way right now in the smart use of data, but so there's a long way to go for many others who are trying to catch up. Now some would say, and I include myself in this group, that this strategy can be game-changing and can go a long way to addressing the number one problem of constantly spiraling healthcare costs. The model I'm going to talk about today is a data-driven population health model. It goes way beyond single medical events. It's part of a comprehensive strategy that helps payers get a handle on which of their health plan and where their health plan money is going. By tracking workforce health risk and targeting intervention strategies appropriately to mitigate that risk, all fully integrated with proven campaigns designed to develop a healthier workforce over a long period of time. Now that's a mouthful, but that says in one soundbite what the strategy and the concept is. Now let's admit at the outset this sounds like a tall order, but there's an increasing evidence that's being done and by a growing number of companies. Any serious effort to address the workforce population health must first confront the principal drivers of healthcare cost growth, namely the excessively high utilization of medical services in the U.S. and also the causes behind the high use of services. Let's start with a quick look at the costs. Now, the cost of the key drivers that are affecting cost. We are looking at a slide that talks about the principal areas where cost is being seen. Growing at an alarming rate, and there's no sign of a slowdown. Survey after survey reports continued increases this year and beyond. It's important to note here what's the nature of the problem in framing this issue. Healthcare spending now outpaces inflation by a significant margin, more than 3 times the projected rates for both inflation and economic growth. For employers trying to cut costs to remain competitive in a difficult economy, these rising healthcare costs present an enormous challenge. It's not surprising that the majority of employers cite controlling healthcare costs as either a high or a medium priority, and this is according to a survey from Aon Hewitt. What are these drivers? What is driving the costs is hospital and doctor visits, the key driver of cost. The average daily visits to doctors and hospitals went up in 2012, and the cost of physicians' care was up 1.3% in 2012, according to the American Medical Association. Prescription drugs, another one. Brand name prescription drug costs, especially costs for high-tech specialty drugs for diseases such as cancer and multiple sclerosis, they continue to escalate. Lab tests, while accounting for a small fraction of total costs, 2.3% according to the CDC, the frequency of such tests is increasing rapidly. Lab representatives expect an increase in demand for lab tests over the next 3 to 5 years, according to PricewaterhouseCoopers Health Research Institute. Technology is also having its impact. Rising numbers of new medical devices, new medical procedures have helped push up healthcare costs. And not to be forgotten, last but not least in this category, are administrative costs, big item. Administrative costs are a key contributor to the overall rise in healthcare costs. One study that I'm familiar with reports such costs represent $361 billion each year, or 14% of all healthcare expenditures in the U.S. The causes of these illnesses, I think, are vital to our consideration of our topic of data today. Chronic conditions, number one. Most cases in most populations, chronic illnesses such as heart disease, diabetes are always present. The CDC estimates that chronic diseases, including heart disease, stroke, cancer, and diabetes, the big four, make up about 75% of the $2 trillion plus spent annually on medical care in the United States. There's another one that I'm sure that we need to keep in mind that's affecting the picture, and that is lifestyle-related risks. People who don't exercise or eat healthfully are at a higher risk of becoming obese or developing diabetes, a growing trend in the U.S. CDC reports that more than a third of the U.S. adults are obese today. Similarly, the harmful effects of smoking are well documented. Employees with these lifestyle risk factors generally cost more to insure. It's not surprising that they do, but they do. And they pay more for their health care. Nationally, employers spend about $190 billion in medical costs as a result of obesity, according to the Journal of Health Economics. And the CDC says that cigarette smoking results in $96 billion in healthcare costs annually. I think at this point one has to start looking at the responses that are out there. What are the options? The traditional employer response over the years has been pretty well cut and dried. Either reduce benefits or shift costs to employees or shift to employee-only coverage. Now, I'll just say it up front, shifting costs is not cost control. This strategy has mitigated some costs for employers, but has largely, I think, been unsuccessful in getting employees healthier or bending the overall cost curve downward. Costs continue to increase. However, I think it's fair to say here that costs related to chronic conditions and lifestyle risks can be impacted with the help of effective data-driven strategies. We're talking about promotion of health, care management, wellness programs, and other preventive services as a response. Studies show that 70% of healthcare dollars are spent on lifestyle-related illnesses that are preventable. And 4 modifiable health behaviors, I should mention lack of physical activity, poor nutrition, tobacco use, and excessive alcohol consumption are responsible for causing most chronic disease, according to the CDC. Shifting to the key role now, topic of today, of how data can play a role in helping to address these problems that I've just mentioned of measuring and managing, which are pillars of the Institute's concepts of healthcare promotion, healthcare performance management. An unprecedented stream of health data is being generated. We all know that we're flooded with information, and some call it a data deluge. And this data deluge is projected to grow 40% each year. So we're looking for more and more and more and more information. At the workforce population level, systems are available today that can capture, leverage, and analyze this planned data. Data-driven analytics and predictive models can track plan usage patterns and spending trends. I hope I'm not preaching to the choir by saying that we're all aware of these developments, but the question is how can we effectively use them? And providing insight into what's happening into the plan, looking beyond the numbers and into the plan, and where are the health benefits dollars going. This technology also can generally identify potential future risk exposures in advance, not only looking historically at what's happening in the plan and looking ahead to project what could happen. And this is to look at the possibility of identifying exposure before illnesses are incurred and before costly claims are filed. And this is a very important concept I would like to stress in the approach of using data for health care population management. Let's start with the first one, which is prescription drug claims data, which a lot of people overlook. It's especially valuable. Prescription drug claims data. Processed in a data warehouse, this information can quickly be analyzed and turned into actionable intelligence for risk mitigation strategies. It can tell us, for example, that a spike in the use of Lipitor is a red flag pointing to increased cholesterol and potential cardiac illness, just as a spike in creatinine is a red flag for kidney disease coming down the pike. This data that I'm talking about here in prescription drug data is accessible in real time. It's shown by research to be equally as effective as medical claims. This is the subject of one of the Institute's white papers that analyzes the use of prescription drug data in conjunction with clinical data and concludes that they are equally effective in predicting risk. Of course, certain clinical data, such as hospital data by comparison, has some limitations compared to prescription drug data, which is available in real time, and that is that the clinical data often has a 15 to 30-day submission window, a lag in which the information is not available, and which often is followed by a 90-day adjudication period. So there's an extended time in which clinical data is not available. And with data analytics, having the ability to identify costly chronic conditions that can be identified before catastrophic health costs are incurred, it's a very important advantage to be able to access data in real time. With the use of this data, risk can be stratified into an overall workforce health risk profile, which is another key dimension to the strategy of having a report of workforce health risk. Health risk force is stratified into high, medium, and low risk, and this is the information needed by the decision makers to target outreach to the right people. And this is all facilitated with a dashboard that's available to look at the data, aggregated and displayed, in a de-identified format. There is no identification of individual, violate HIPAA. It's all HIPAA compliant, encrypted information, and anonymity of individuals. And this data in the aggregate can be converted into actionable intelligence as a basis of making decisions on how to proceed. Let me give you an example of the dashboard. A plan, let's say hypothetically a plan, we have a plan with 3,500 enrollees, and the decision makers have a dashboard view of the firm's prescription drug claims data. An analysis of this data shows that 78 of the enrollees in this plan of 3,500 enrollees are at a high risk for future costly claims, and also shows that these anonymous enrollees have 9 unique chronic medical conditions. This is not uncommon with people at high risk to have multiple chronic conditions such as diabetes or cardio issues or obesity, etc. With the use of the technology that relates to a predictive modeler, which is in many instances combined with an embedded simulator, able to project that there is a 54% chance the plan will have approximately 4.4 million cost exposure in year X. That's a valuable piece of information for the decision maker looking ahead, that the plan faces this kind of a risk exposure going forward. With this intelligence, plan design changes can then be adopted in a more informed way. Less expensive alternative drugs, for example, tiered co-payments, preventive health screenings integrated with targeted outreach, health promotion that's available as part of the process to mitigate risk. I want to talk a bit here at this point about predictive modeling, because it's a very important part of the process of using data in the context of population health management. We in the Institute have looked at a predictive modeling system developed by Johns Hopkins Bloomberg School of Public Health. Very effective modeler, very widely used. It was developed in 1991, and this program is an industry standard predictive modeling software program. It's based on a computer algorithm that can assess the health of people enrolled in a given plan against statistics in a proprietary global base of over 80 million lives. So there's a basis of comparison with the predictive modeler. With the right software tools, a company can capture plan data, synthesize and analyze vast quantities of typically disjointed plan data, and compare this data against outside databases, and then display the results on a corporate dashboard at their fingertips, at their desk. This process is very valuable. It not only enables business leaders and human resource leaders to use where to see where benefit dollars are going, but it also gives them insight into where potential costly workforce health risks are going to be moving in advance and before they occur. We come now to another key component of the process. We've talked about data, capturing data, analyzing data, creating intelligence, having a dashboard with options that identify past risk and future risk. Now we come to the key, which is, how do we make all this work? How does this process move ahead now to the next step, which is a way of getting greater population engagement in the whole process? A unique feature of the population software allows this predictive data to be integrated with targeted, risk-specific employee communications. This is outreach, customized, and education and management programs designed specifically to mitigate risk. This all, of course, depends on the employee readiness to modify behavior. Some employees are less susceptible to behavior change because it's part of our human nature that happen. We all know that chronic conditions are more a result of individual lifestyle choices than natural causes. The very human traits that influence lifestyle behaviors also can affect our health. That's why tested scientific principles of behavior modification can play a big part, that we have found in the work we've been doing in the Institute, in greater individual engagement in health. By the way, a white paper released last month by the Institute goes into some detail about this scientific method, and I won't take the time to elaborate on that today. So suffice it to say here that the workforce health risk profile must be integrated, and that is another key, integrated with highly targeted health promotion and care management campaigns. And then this is targeted to very specific employee health risk. If our analysis has shown that the greatest proportion of the workforce is at risk for diabetes, then of course the targeted communications are risk specific to that chronic condition. And at the same time, we were able to access health and wellness tools, sophisticated tools that lay out the response to the chronic condition. The system, the software computer system that I'm talking about, also facilitates secure communications with providers and care managers, and can increase compliance via mobile and electronic alerts. So what I'm saying here, you have two-way communications between the care managers and the patients, all integrated with a campaign that's targeted to the specific illness, and which is and all aimed at stimulating greater employee engagement. All of these concepts are nice to talk about, but they still have to be implemented, and it's true. We know in today's dialogue that financial incentives have played a big part in getting people involved, and with those financial incentives, either carrot or stick, although it seems to be in the current environment it's more stick than carrot. Customized specifically to workforce subgroups. In other words, we have a subgroup in the population that is at risk for, let's say, high cholesterol exposure to cardiac illnesses. Then that's a subgroup, let's say, of the population in the aggregate. It's not personally identifiable. We don't identify individuals. That is not the way it works because of HIPAA. And I might add at this point that a very key element to this whole process is the involvement of registered nurses who are serving as health coaches in working to reach out to employees by phone, online, or on-site. After they have volunteered, they've been given the opportunity to step forward and volunteer to participate in these programs and campaigns. With this information available to the nurse coaches, they're more intelligently able and proactively able to assist and encourage engagement in wellness and lifestyle behaviors. So that's sort of an overall summary of the process. There's one last remaining item that I need to talk about in this context, and that is automation. Automation is inherent in keeping all of the pieces together. Automated workflow processes is the glue that holds everything together. And campaign management tools to support member engagement are embodied in this overall system. This enables the security of the workforce process, enables relationships and content and communications to be managed from a single interface, on a single platform. All of this data that flows in from disparate sources, and it's available data of exposure to chronic conditions, data of care management processes underway, all managed with a workflow process system. At the same time, the care managers who are working with individuals who have volunteered for the programs can access patient-specific risk profiles and track and manage member interaction and manage member outreach. All of this comes together as part of the comprehensive population process. Now, I come to the last point before we move to some questions that are coming in, and that is to give you an example. I think many may be wondering, well, this is fine to say, but does it work? Do you have any evidence that it works? As I said at the beginning, the strategy we're talking about is promising. Early results are promising. It has increased member engagement, it has improved health outcomes, and it has reduced costs. So one example is a company called Viking Range Corporation. Viking Range is a Mississippi-based, self-insured, high-end kitchen and appliance manufacturer with 800 employees. So it's a mid-range employer, not small, not large, about 800 employees. Viking Range saved $1.16 million in medical and pharmaceutical costs over a one-year period by employing the principles that I've been talking about. Faced with constantly increasing health costs, the company needed deeper insight into why were their costs increasing. And based on the data analysis tools that tracked projected costly health risks, the company initiated extensive outreach to engage employees in health promotion and wellness. And over a one-year period, this resulted in a reduction of 16% in annual medical and pharmaceutical claims costs per employee. It also identified a projected 13% in high-cost claims. Now, we have also published in the Institute other success stories, other companies that have become advocates of the concept of applying business principles to their health plan performance, and these are available on the Institute website at www.hpminstitute.org, and they're free of charge. People who are interested in looking at some of the work, including white papers, research reports, podcast, webcasts, a whole series of work that has been aimed at advancing the concept of population health management. Although we started by calling it healthcare performance management, it's all the same. Healthcare performance management has sort of merged over into population healthcare management as a big picture concept today. So there you have it. I think I've laid out the basic elements of a data-driven population healthcare program. And so I hope that this has taken. I'm reminded of a Sunday morning news talk show that I listen to occasionally that has a segment called "Tell Me Something I Don't Know," and this elicits one idea from each of four panelists that perhaps has not reached the mainstream media circuit yet. So I hope we've communicated at least one or two ideas that you find useful and that you can employ. And we are now moving to the next stage, which is to offer briefings on this to individual companies that are wanting to learn more, to understand how this all works. So that's a benefit that's available as a public service to followers of the Institute. We have over 1,000 people registered as a database in the short 3 years of our existence, and we're hoping to expand that. So with that, I come to the conclusion and hope that we have some time left. Yes, I see we do, for questions. Rita, you've been following the questions. Do you want to start us off with what you see?
Sure, George. Thank you so much for that. That was really illuminating. Yeah, and one of the questions that I have is actually a question that I, wanted to ask you myself, and it has to do with privacy concerns. When I did the story on Viking, one of the things that we talked about with their HR director was that I asked her if employees were reluctant to be a part of these wellness initiatives, to give all their information on their health to these nurses that work one-on-one with them, these health coaches. And so one of our audience members has a question that is relevant to that. And this person asks, what keeps employers from making business employment decisions based on this information? For example, if it has become known that an employee has a chronic condition that will result in increased healthcare costs, undocumented decisions and actions can be taken that lead an employee to being ushered out of the organization. How can safeguards be ensured when this technique is used? So that's a question that comes up often with regard to data collection, is what are the privacy concerns here, and how can employers address those?
Thank you, Phyllis. I'm sorry, Rita. This is a key question that comes up often, and in my previous incarnation practicing law, deeply engaged in the whole privacy issue and how HIPAA relates to various aspects of employee benefits, including the health plan. Let me tell you at the outset, in terms of the safeguards that are built in that allow this process to go forward. HIPAA includes some very important language, which I'm sure most people who are working in this area are aware of, and that is those people who have to handle claims data or personally identifiable information related to the administration of the plan do not need to receive consent. The consent is basically legislated out for those who are business associates and are able to process claims and where you have access to personally identifiable information. Now, with that said, there is a very important aspect of population health management which requires that this information be encrypted as far as it relates to individuals, that individuals remain anonymous, and that there is no specific data that traces individuals to chronic conditions. However, let's say in a typical situation, an employer offers a smoking cessation program to those employees who wish to take it up. That is information that goes to the workforce in general, and those who are interested in looking into it can voluntarily step forward and identify themselves and say, we're interested in learning more about this. That's where the process begins. So at that point, the individual voluntarily identifies themselves and consents. So there's no attempt to violate the privacy provisions by identifying people who have a chronic condition without their consent. So that is an important part of this, and as the process unfolds and people become involved with nurse coaches, then they're one-on-one, or they're doing it by phone or on the internet, or they're doing it in some other way in employer clinics where they step forward. So I hope that answers the question that there is no transgression of the privacy provisions here under this process. You have another?
Yeah, George, I was wondering, you talked a little bit about just how much data there is out there, how much healthcare information is being produced due to the trend toward more greater healthcare consumerism, legislative and regulatory demands. Can you talk a little bit about that, sort of the evolution of healthcare data?
Yes, I'll be glad to. I'm looking at this point in data, not necessarily from external sources at the outset, but tied into plan data. The health plan is a virtual gold mine of information. It's a treasure trove of hidden information with hidden opportunities to identify risk. You have claims data, as I mentioned. We have prescription drug data, clinical data, treatment data, hospital data, doctor data, lab data, x-ray data, screening data, all of this data that is electronic health record data, all in disparate silos, disjointed, and not coordinated. And the need to take the step now that is everybody seems to agree needs to be taken is the connectivity of all this data in one place, in one silo, in one platform, to be able to use data warehouses, analytical data analytics, to drive the intelligence we're talking about. So this has been one of the problems that has impacted significantly on the high costs, is that there's duplication and there's decision making that takes place without knowledge of all of the pieces and all the pieces of the puzzle. So the ability to integrate all this data into one database, one silo, and make that same data available to the doctor, to the payer, to the patient, to the caregiver, so they're all working on the same page, I think is critical in our attempt to solve the population health problem.
Thank you, George. We have another question that is related to privacy again. Seems to be a hot area here when it comes to healthcare analytics. So the question is, you mentioned, George, that certain business members have legal access to healthcare data, and it's those people we have to worry about, our audience member says. Perhaps big data techniques could be employed to observe how many chronic health problem employees are being terminated, terminations that are seemingly unrelated to the health condition. Can you elaborate? Can you talk a little bit about that?
Well, I would like to draw the distinction between plans that are insured and plans that are self-insured. The whole concept of population health management works much more effectively with the self-insured plan community. I previously served as general counsel to the self-insurance industry in an earlier incarnation and wrestled with this problem on a regular basis. The reason it's important is because there is sort of a proprietary distinction out there between insured plans and self-insured plans. Insured plans are much less likely to want to provide access to this data. They take the position that it's proprietary. They own the data, and many times their contracts, their premium, their insurance contracts, their policies have language in it that make that data their data. So they're not as willing to divulge it. Although there was a legislation passed in Texas a few years ago that under state law requires insurers to divulge claims data on demand under certain principles. Now, on the self-insured side of the equation, this is an issue that has been at the heart of the distinction between insured and self-insured. There is a Chinese wall that's put up in most all companies who administer self-insured plans between the business decision makers and by the administrators of the plan. The plan may be administered internally, internal administration, or it could be, but most of the times it's administered by a third-party administrator, a third party, either an ASO or a self-standing third-party administrator. Under those circumstances, the data that we're talking about is in the possession of people, sources, of vendors outside of the company. Vendors, service providers who work with the company in administering the plan and also in making these programs and systems available. So, and that draws the line so that the decision maker is not going to be available, not going to necessarily be aware of who has the chronic condition that we're talking about. Although, you know, I mean, in the real world, some of this information may come to the attention of decision makers, but I think it's in the minority of circumstances that this has become a problem. At least I'm not aware that we have had significant issues where people have been fired because they've got taking too much Lipitor.
Thanks, George. We have a couple of questions about software. So one of the questions is, what are some low-cost software that we can use to analyze data?
Well, you're asking specifically about low-cost software. I'm not here today to promote any software. I'm here to promote a concept of how software can be used. There are multiple sources, and I'd be glad to try to share some of that information with people offline if they're interested. But I think that the cost of providing software technology that can perform these tasks that I've been talking about is very, very minor compared to the cost of having to pay increasingly high medical bills. It's generally on a per member per month basis, which is I think a common way in which certain types of services are made available to third-party administrators or to self-insured employers or to those who are interested. And I think the beginning point is to embrace the concept, and then once that has sort of been driven home, to get into more detail about the specifics, and that can be done in a number of ways. I would recommend, number one, a webcast briefing that could take place about 30 minutes to 45 minutes. You don't even have to leave your office, just like today. You could do it right online with you, and then you have a chance to talk to the people who do these things and to get more specifically involved. But the cost of this is a competitive issue among a lot of vendors, and I'm not here to push one over the other.
Great, thank you, George. I have a question about employee communications and HR's role in collecting data and developing these wellness programs and all these initiatives that you talked about. From the employee's side, what are employers telling their workforce about these initiatives? Is it important to get employees on board explaining the rationale why you're collecting this information? You know, if you could talk a little bit about, you know, sort of from the employee side, what they need to know.
Okay. Well, this is really a win-win situation for everybody. It's a win-win because the employee is now being hit by increasing out-of-pocket costs, higher deductibles, co-payments, a sharing of costs between the plan and the employee. I think employees are generally aware, because it hits their own pocketbook, that costs are going up. And from the employer's perspective, looking at the positive vibrations of offering a program that allows employees to improve their own healthiness and their own wellness is a win-win, because if it's done properly, it can create less demand for utilization of services like hospital and doctor visits, can cut back significantly over a year, maybe even sooner, on the cost of medical service utilization. And from the overall, in the overall perspective, I don't think that there is a significant issue here of let's say, why are you collecting this information? Why do you need this information? I think it's generally understood that the costs of healthcare are hitting everybody, and that there needs to be some action taken to solve it. And with a tested and proven communications program, which many of these integrated programs offer, and I must say that these are not just generic communications. These are customized communications that are aimed at individuals who are wondering, well, I don't think I can do that, or I don't have the time, or you know, there are a lot of reasons why people are not interested in taking steps, behavioral issues, and I think the ability of a company with seasoned registered nurse health coaches and care managers and wellness advocates and health promotion, lifestyle promotion people, that they have developed the skill set to interact with people and allay their concerns and relieve some of their anxieties about this. So I think this, to a great extent, this whole issue of privacy has been overplayed and has been overdone. And as one viewer of the scene, I can say that I feel that the proof is that when people become aware of the fact that there's some help for them out there, and that it's being offered as an employer benefit, that it's all aimed at developing a healthier workforce. This is a very important competitive reason why people might want to work for a particular company, because they want to be in a company where there's a culture of wellness and healthiness. They want to be a part of a corporation that is concerned about their employees, and that's really the other side of that question.
Thanks, George. Yes, there's no doubt that that data collection and analyzing the healthcare data can really help employers when it comes to healthcare costs and improving outcomes in some pretty dramatic ways. You mentioned Viking and the fact that they saved $1.6 million after employing some of the strategies that you talked about today. They have an interesting story, because they're located in the Mississippi Delta, where obesity and diabetes are rampant, and that's reflected in their workforce. And they have developed, through the use of data, analyzing data and collection, some interesting programs. Can you give just maybe one more example of how companies are using predictive modeling to address some of these health issues and cost issues?
As I mentioned during my presentation, the first level of concern is to bring down the cost of health plan utilization, and that's registered in the claims that are filed. That's an important aspect of this. Another aspect of this is not only the direct costs that are involved in the payment of claims, but there's some indirect issues that arise, including absenteeism. It's, I think, no big secret that when people don't feel good, they don't work as productively, and that there are numerous studies out there that point to research that shows that one of the causes, one of the direct effects of